Great. So I'll be doing a bit of a description of the epidemiology of monkeypox in the UK and also a bit of a deep dive or focus in the northwest of England. The data that I'm presenting today is all publicly available. It's been published either in technical briefings that have been issued by the UK Health Security Agency or during our latest EPI report, which was released actually today. And I'm representing, of course, a large group of people working on this to make sure that you are equipped with the best data that we can provide so that the outbreak can be controlled. I think to begin, one of the key points I want to make is that monkeypox is an infection that has been circulated for a few months in the United Kingdom now. When we look at the first cases that were identified in the country, they were identified in May. But when we did a look back exercise trying to talk to people who had similar clinical presentation to the one that we were seeing in May, we identified a few cases who actually started their symptoms as early as April. So that's basically to say that it's not so much an importation that has happened just in May or June, but it's very likely that transmission has been happening in the way that we're seeing now for a few months, probably at a small and undetected level until cases started growing. And in what we see in the figure to the left is the number of cases by date of onset date. So that's the day in which the symptoms start for cases in the whole country, in the whole of England. The dashed line represents more complete data. What is at the right of the dashed line is more incomplete data, or cases where we don't yet have full information. So it's expected to be updated with new cases as we identified further information from laboratory networks and enhanced surveillance. Currently, we have almost 2,800 cases in the whole of the UK, most of which are in England, 2,638. And we're seeing a week-by-week change of around 200 cases, 300 cases. So even though the figure to the left does show maybe a slight decrease in the number of cases in the last few weeks, we know that this is not the case. It's just that data keeps on coming, and that as cases come forward and are tested, we identify more cases. And we do think that the epidemic is still growing, maybe not at the highest rate, but we do think this is still an outbreak that is growing. And it's an outbreak that has particular characteristics, specifically in the term of the population that it's affecting. We know that over 95% of the cases that have been identified so far are male. And for the purpose of this slide, we use this binary definition of sex, really, female and male, because that's the way the laboratory data is reported through those pipelines. But there's a diversity that represents the LGBT community more widely within that, and I'll tap onto that in the next slide. But what I want to show here is, even within this binary sex classification of men and women, what we're seeing is that most of the cases are in men. And that's not necessarily representative of just the testing pattern. When we look at test positivity for adult men, we have 1 in 2 tests coming forward as positive. In the case of women, we're seeing around 2% of positivity, meaning that even when being offered with testing, we're not seeing as much transmission in women. And this includes both cisgender women and transgender women for the purpose of this one analysis for test positivity. But in general, that's to say that it's not so much a problem of us not finding cases outside these groups that are well characterized, but that we do have good information to think that transmission is happening in these groups. And which are these groups? We've done the best we can in terms of enhancing the data we get from laboratory networks with epidemiological information. And for the purpose of that, we've been interviewing cases, whether this was through phone interviews, and then it was through self-completed questionnaires or questionnaires administered through health protection teams, where we ask people to identify their sexual orientation and their behavior in order to characterize the outbreak. And we've consistently found, week by week, and that's what's being represented on the trend lines to the right of the slide, that there's a very homogeneous population in a very broad sense that is being affected by this outbreak, by this infection. And that's mainly people who are gay or bisexual, or men who have sex with men who identify differently. Most of the cases identify as gay. They're mostly gay men, but there's also bisexual men, and there's also men who have same-sex behavior but identify as heterosexual. Of course, one of the first questions we asked was whether this was an importation of cases, whether we were seeing cases imported from other countries, or whether we were seeing true transmission within the UK. And the truth is that we've seen 30% of travel history in cases, and that has not really changed that much week by week. So I know it's a bit small, but you may see a bit of a trend here. And we have between 25 and 40% of people who travel or who traveled outside of the UK before they started with their symptoms during the incubation period. So it's both a mix of domestic acquisition, but also acquisition internationally. So we know that any efforts to contain the outbreak nationally also need to be hand in hand with a more global effort to make sure that we're containing and controlling. And other characteristics that are relevant include the history of a previous STI in the last year. So about 1 in 2 cases do say that they had another STI in the last year. And I say another, fully aware that monkeypox is not an STI in the truer sense of the word, because sex is not a fundamental factor in order to facilitate its transmission. But it's true that monkeypox is being transmitted in networks where other infections are transmitted, usually STIs. And in that sense, it makes sense to target some of the efforts to control the outbreak to the same groups of people that are being affected by STIs, for example, and that will be reflected in some of the control interventions that we're doing. We also see that there is a higher representation among people who are being affected with monkeypox of people who have more than 10 sexual partners. So we are seeing that people who are affected with monkeypox have around 30% of them say that they had 10 or more sexual partners in the last 3 months. That's higher than what we usually see in the overall population. And some of these analyses are allowing us to triangulate that, in fact, it is through sexual contact that people are acquiring the infection. And the more contact that people have with one another, the more likely they are to transmit this infection. The proportion of people who are living with HIV is around 25%, sometimes 30%. It varies week by week, but it's quite consistent. And the good news is that most of those people who are living with HIV and have diagnosed HIV are on treatment, are undetectable, and are quite adherent to the medication. And among those that are HIV negative, almost 80% have ever used PrEP, meaning that there are strong links between sexual health services and the people that are being affected by the outbreak, which highlights the role that sexual health services play in ensuring that we can reach these groups and make sure that we can deliver interventions to support the control of the outbreak, but also to improve their health. We've also been trying to understand where people may be getting their infection so that we can ensure that we're targeting interventions in the right settings. And there's this is imperfect data because it's reliant on questionnaires and on interviews that are not always in depth, but also not always possible to do. So this is specifically for a subset of around 275 cases. And we found that 1 in 3 cases had attended a large festival where they said they had some sort of sexual activity. 25% has attended sex on premises venues, so saunas or membership clubs or swingers clubs where they may be having sex with new partners, and so on. The other settings are maybe less so represented, but specifically the work with festivals and the work with sex on premises venues seemed to be important, and making sure that we were engaging people who were going to festivals throughout the summer, such as Manchester Pride soon, or Brighton Pride, for example, this coming weekend, or linking with sex on premises venues or places where sexual activity just takes place in commercial settings, is a really good approach to make sure that we're reaching the right people. Integrating all of this data into our assessment of what's going on with the outbreak and trying to understand what's the risk of the outbreak being transmitted beyond sexual networks and into different settings, such as not on sex on premises venues or in different subpopulations. Integrating all of this information, we continue to say that we are in a level 2 outbreak, which is an outbreak that is affecting a defined subpopulation, and we don't have any signals to think that there is a large movement of the infection from a very well-defined subpopulation into a larger subpopulation or a different network. And this definitely does not decrease the importance that the outbreak has for public health, for control, and for individual health. But it allows us to make sure that the measures we're taking are targeted to to make sure that they're reaching the right people, as opposed to broadcasted or very broad interventions that will reach everyone in society, where the information may not always be relevant to everyone. So it's definitely a tricky balance to achieve between targeting, but also making sure that there's wider awareness. And this is a bit more detailed information on the Northwest. And I think first I wanted to look at the trend line and the curve in the left. So the one in blue, that's the trajectory for London. So we'll see that London had a very sharp increase in the number of cases throughout mid to late May, and that has continued throughout June and July. And the black line represents places different than London, including all the other regions, where the trajectory is also one of growth, but maybe a bit more delayed compared to London. And for those of us who constantly work with national surveillance of outbreaks of STIs or infections that are transmitted in sexual networks, this was very much not surprising. This is very similar to what we see for other infections. And what happened after is also what we see for other infections. So the Southeast is in green and the Northwest is in purple. And this is specifically driven by demographics and by people's integration into communities and migration. So areas like Brighton, for example, in the Southeast, or Manchester in the Northwest are definitely places where we're now seeing increasing transmission. And in our latest report, Manchester, well, the Northwest in general, had 144 confirmed or highly probable cases, which is the current case count we're going with for the Northwest. And when we look at within Northwest distribution, we see that on a week-by-week basis, most of the cases occur in Greater Manchester. It varies, so sometimes it's been as high as 88%. In the latest weeks, it's been a bit lower, towards 62%, potentially signaling transmission beyond Greater Manchester into other areas of the Northwest. But in general, the epidemiology in the Northwest is not being too different from what we're seeing in other parts of the country. So 99% of cases are male, 95% of cases identified either as gay or bisexual, or other men who have sex with men. So the control interventions do not vary regionally in terms of what is suitable to control the outbreak. And we have a vaccination strategy that will be covered elsewhere in the presentation as well, but it's a targeted pre-exposure vaccination. It's important to know that this is not a vaccination program, but it's a strategy. And the difference is that a program is usually long-lived and has a broader aim. A strategy is more short-term effort to, for example, control an outbreak, such as in this case. That's not to say that this won't evolve into a larger, more ambitious program further down the line based on what we see initially from the vaccination strategy. But it's mainly targeting people who are at increased need, really, not just risk, but need of having prevention services offered to them. And there's a number of proxies that we're using to make sure that the vaccination is being offered to the right people. There's also post-exposure prophylaxis for people who might have been exposed following contact with a confirmed case. So that's it from me. And I don't know, Lauren, if you want to take questions now, or maybe we should wait till the end.
Yeah, I think what we said we were going to do is wait until the end, but there have been a couple of specific questions for you, Matteo, so I might just go through those now. Mm-hmm. So one question was, do we know the R number?
We don't, in the sense that the R number is rarely a direct measure that you can garner from the epidata. It's usually an estimation done through modeling. And it requires a number of parameters, such as the number of contacts that people are having, but also needs to consider things like secondary attack rates, which is basically the proportion of contacts that are becoming cases. And one of the big limitations of this outbreak is that because of the nature of sexual contact, which oftentimes is anonymous, it's really difficult to calculate the number of people that some of the cases are having sex with. So that does bias the estimates. In general, what we're doing is something called nowcasting, which is an approach to modeling to basically know how much infection we have at any given time using some modeling techniques on the data. And what that shows is that the epidemic is likely to be growing at a very slow rate. So we know transmission is still happening. We know this is not shrinking, but it's definitely not growing exponentially.
And then there was another question, which I think this is a good time to bring in Dr. Chris Ward and Dr. Chitra Babu, who are both here, because there was a question around how Manchester links with this data and how Manchester compares to the rest of the country. So Chris Chitra, did you want to jump in at this point?
Yeah, I can jump in. So I'm Chris Ward. I'm a consultant in sexual health and HIV at the Hathersage Centre. I'm also a officer for BASH, which is the British Association of Sexual Health and HIV. So I've been sort of feeding into coordinating the response to monkeypox on a national level as well as in a Manchester level. So we saw our first case here in Hathersage probably mid-May time, and I've had sort of we probably had maybe about a bit like COVID, 2 or 3 week lag behind London, really, before it began to sort of grow exponentially. So Hathersage is one of 4 clinics in Greater Manchester. So we have clinics for Withington in South Manchester and North Manchester General and also Trafford, as well as the infectious diseases unit in North Manchester General. And between the 4 clinics, I think we've seen the majority of monkeypox in Greater Manchester and majority of monkeypox in the Northwest. We've probably seen about maybe 90 or so cases. And so we are seeing quite a lot of it. Presenting, almost exclusively in GBMSM, and it's very interesting seeing Matteo's presentation, and it's very similar situation that we're hearing on a local level compared to national in terms of demographics. We certainly had a little bit of spike after Gran Canaria Pride. We had a little bit of spike after Darklands in Belgium. So, association with fetish events and festivals, we certainly saw. And we're seeing a wide range of presentations of monkeypox on a clinic level, from people with multiple different lesions in multiple different areas to people presenting just with 1 or 2 lesions at the site of sexual contact. So we are seeing it. We try to coordinate our clinics response to monkeypox. So we have a flow chart and a pathway that we're using in all of our northern clinics. I can only really speak for northern about how we're dealing with monkeypox. The national advice when it first started was to sort of try and triage these. So we have a designated phone triage of anybody presenting with rashes, and then we try and fast track them where possible into a face-to-face review for assessment by an experienced clinician. I'm happy to answer any of the clinical questions. I'm not sure if I answered that question correctly, Lauren. Let me know if I went off topic.
No, I don't think so. There have been lots of questions about comparisons of the vaccination programme in London and Manchester, and I know that obviously we will cover that in some more detail when Liz talks about the vaccine programme. So just to reassure people asking those questions in the chat, but we will cover your questions. Yeah, Paul, it will be Liz Lamerton who's here from the vaccination team. So Chris Chitra, was there anything else that you wanted to add about how you've been experiencing monkeypox as a service, or shall we move on to Liz?
I think the one thing that I do want to mention, though, is I was speaking to some colleagues in Chelsea and Westminster in London who were seeing very similar. What we've found as one of the consequences of monkeypox is that we've had a 30% reduction in standard clinical activity because of monkeypox, because the way that monkeypox was originally classed as a high consequence infectious disease, the way that it had specific PPE requirements, isolation requirements, testing requirements, transport of specimen samples, obviously we've had to have a very robust testing strategy, and all of this is very time consuming. So in the background of sexual health services that have been, feeling the stretch of public health cuts for, a decade now, we are already struggling with access, and monkeypox has come at the absolute wrong time, immediately post-COVID when staff are still off sick. And obviously our service helped a lot during the COVID response in the acute hospital. But we're sort of seeing a 30% reduction in clinical activity because we're having to divert a nurse to man a phone line all the time. a doctor to look at the monkeypox assessments. We now need to divert somebody to do the monkeypox vaccine prescriptions. So I think this is one of the things we need to sort of address nationally. I know it is something that's been having, these are discussions that we are sort of having with government really around sort of funding sexual health services, and obviously we have sort of commission colleagues on the call, and we have managed to tap into some emergency monkeypox funding. But I think that's the other impact it has on sexual health services. So it's, you know, with the 30% reduction, we're running behind with PrEP, we're running behind with STI availability, contraception, and it is having a massive effect on our clinic. But this is being felt nationally. And we are doing what we can to sort of try and increase resources and work a bit more efficiently to try and deal with that. So I know it's quite frustrating for a lot of people who are struggling with access already, you know, but you know, we are looking at trying, we are mindful of that, and we're trying to look at addressing that. Chitra, do you want to come in at all?
Yes, thanks, Chris. So I'm Chitra Babu. I'm also a consultant in sexual health and HIV. So Chris and I work together. I'm also clinical lead for Northern Sexual Health. So I'm just going to speak a little bit with my clinical lead hat on, and just kind of say to everybody that it's been quite a steep learning curve for us as well. You know, this was an infection I might have read about maybe in med school and then not. And I still remember getting a text from Chris about it towards the beginning and quickly doing a search. So in the past few weeks, our response to monkeypox in sexual health has also been one of, you know, kind of trying whether what works. And as Chris said, on a background of, you know, poorly resourced services, we've had lots of cuts nationally to sexual health services. And it was just the time when we were trying to make a recovery after COVID when this hit us. So I've not looked at all of the chat, but I've seen when questions have come up of people struggling to get through. And I can only speak for the Northern because that's where I work and I lead. And, you know, these are frustrations which are completely shared by us too. The fact that we can't get patients who need to be seen or assessed for whatever reason, monkeypox or PrEP, are not able to access the service, that frustration is shared by us. Our response to monkeypox was quite prompt, and you know, we devised pathways and everything really quickly. But because this was an infection which was ever changing and which we were learning about ourselves, maybe some of the messages that came out were slightly mixed and confusing, and simply because you know, things were changing so fast. But we have tried to do our best and make it as smooth as possible, and really tried that other things, whether it be our PrEP access or access to contraception for our, you know, other patients, is not affected. But it goes without saying that it has had a huge impact on our capacity. And our trust has been very supportive. We have been granted extra resource, but it's something we are trying to address all of the time. So Lauren, I can see there are some questions for Chris and I, but if you can just read out to the, without us changing the screen, that'd be really helpful.
Absolutely, yeah, I can start. So I'll start from the bottom and work my way up. So Chris mentioned that the increase in services has seen delays to other services. In terms of monkeypox testing at the moment, what are the current waiting times to get a result?
So I can answer that purely because I'm not on mute. So there is some good news. So up until very recently, pretty much till yesterday, all of the tests from across the country used to go to a reference laboratory in Porton Down, which is called Ripple. And I have to say the positive results, they did have a good turnaround time, and we would get them back within 24 to 48 hours. And we were able to, you know, virtually assess our patients and be able to see what care they need or hand them over to a specialist infectious diseases team. As the number of tests carried on across the country went up quite massively, their turnaround time for negative results increased and increased, whereas previously we would get them back in 24 to 48 hours. More recently, it was taking several days, up to a week, which is not ideal. You know, it's good that on one hand you get the positive soon, but on the other hand, you have patients unnecessarily having to isolate when they have negative results. So this is something, again, the frustration that's been shared by us. But more recently, and again, I'm speaking for the trust that I work in, Manchester Foundation Trust, we have introduced in-house testing as of yesterday. And as a result of that, the access to results will be quicker. I won't be able to give a time frame, but definitely positive results within 24 hours and negative results sooner than what we've been experiencing recently.
Yeah. Okay. Another one was around how appropriate you think it is for sexual health services to be leading on the monkeypox outbreak, given that this isn't an STI. That's a big question. I'm happy to wait until the Q&A at the end, or if you want to try and tackle it now.
I think we're the experts here. I mean, I think it is. It's not an STI in the classical sense. It is transmitted through skin-to-skin contact. But you know, as Matteo said, a lot of monkeypox is being transmitted through sexual contact or in settings where sex is happening. So, you know, because a lot of this is being transmitted through sex, I do think it is most appropriate that sexual health clinicians are assessing and seeing and responding to this. You know, I mean, on the flip side, you know, as I've banged on about a lot already, you know, this is on the back of an already overwhelmed service with limited funding, you know, so that is a challenge. But we're the experts around asking about sex. We're the experts around examining funny rashes on the genitals. And certainly in the very early days of monkeypox, we were seeing, you know, well, we hadn't seen any monkeypox before, and you're looking at genitals and very used to seeing spots and hairs and herpes and things like that. You know, this looked very different, and you need somebody with that skill and that confidence in looking at funny rashes and looking at genitals to be able to assess it. So I do think it is right, and it was right for it to be mainly directed into sexual health settings and sexual health services, because we're the experts around asking that. You know, and we're also the experts around talking around contact tracing as well. So when we're talking about trying to, you know, break the chain of infections and dig into sexual networks, we've got a lot more experience of that than other settings have. So I do think it is appropriate, but what we do need is we need it to be appropriately resourced, you know, as this goes on.
And I think another thing I'd like to add, again, talking about the MFT, or Manchester Foundation Trust response, even though the bulk of this work is falling upon sexual health services, which I think is right for all the reasons that Chris said, it has truly been a team effort. So our colleagues in infectious diseases, in AXA, in virology, in the labs, they've all worked together. So we were so prompt in coming up with a pathway for patients. And this was truly the result of teamwork. So even though a lot of the work, especially with testing, vaccination, is falling upon sexual health services, we do have our colleagues from other specialisms helping us in this.
Lots of the questions that are coming through are about vaccination, so I'll wait until Liz has spoken to go over those. But one of the other ones that did come up was, oh, it's tricky to find them in the chat, isn't it? It was around presentation and what kind of symptoms are you seeing? Because I know that in lots of cases, the symptoms that originally were reported as the main symptoms of monkeypox might not be what doctors are seeing in their patients.
I mean, I think, you know, I mean, Matthew is the absolute expert on this, you know, but we are, certainly from speaking from my own personal experience of seeing, you know, 20, 30 or so of them myself, it's a real range of presentations. So we do see a lot of genital lesions at what we would call herald sites, which is sites where sexual activity is happening. So you see it around the lips, you see it around the penis, you see it around the bum. We are seeing a lot of people presenting with what we describe as proctitis, which means infection or inflammation of the rectum, the end part of the bum. which is probably because the monkeypox has been directly put there through sexual contact. So we do see this classic presentation of it being around sites or sites of the body where sex is happening. But then we also see the other half of the presentations. We're seeing lesions elsewhere. I've seen lesions on the hand, on the arm, on the back. Some people have only had 1 or 2 lesions. Some people, the most I've seen is maybe somebody with about 40, 50 lesions all over the body. It's a real mixed presentation. I think we're still a little bit too early in our knowledge of monkeypox to know some of the reasons why that is. From a symptom point of view as well, a lot of people are having what we would call prodromal symptoms, which is sort of other symptoms not related to rash. So people get a sore throat, some people get fevers, some people get tiredness, but certainly not everybody gets those symptoms. And some people are getting those symptoms before the rash, some people are getting the symptoms after the rash. And then the other thing that we're noticing is maybe about 20-25% of people we're seeing have some other STI as well. So we are seeing people present with other signs, other genital symptoms as well. That's my experience. Matteo, I don't know if you want to come in, because I know you've done a lot of data on this nationally, haven't you? Sorry.
Yes, so I think just to completely echo what you said, Chris, there's such a heterogeneous presentation that any case definition we put forward will not be completely accurate to every case. And the idea is that we have something that is sensitive enough. So we find everyone who may have monkeypox, but does also have some specificity. So we're not testing people with a different infection. And I think a good representation of the fact that the current case definition that we're using is a good one is that out of 2 people who are being offered the test, who are adult men, 1 of them has the infection, meaning that we're probably testing the right people. I would actually go even further and say that we may want to bring that positivity down. We may want to offer testing more widely, and that's something that's being evolving as we ramp up the laboratory capacity as part of the outbreak.
So I think the only other thing I'd like to add is, as I said, that we ourselves have learned about the infection as we've gone along, and the initial case definition of an unexplained rash or a sore. And we very quickly learned that proctitis, or inflammation and pain around the bum, which could be bleeding or pain, and that became quite a common feature too. And very recently that's been added to the case definition as well. So that's another quite not uncommon symptom that we come across.
And I think if I can just add something to that, it's exactly because of that. It's exactly because of that ability of sexual health services to talk to gay men, to talk to bi men, and be able to get a sexual history, that gay men are coming forward and saying, actually, I have pain in my bum, I had anal sex. That's not something, as a gay man myself, I know that that's not something that usually people will tell their GPs or that people will necessarily share in primary care. And that level of trust, that level of rapport can be well established between the community and sexual health services, which really helps to shape how it's an initial setting for assessment and triage and management of the outbreak.
So thanks for that, Matteo, and obviously to Chris and Chitra as well. We are running slightly behind, as I think we all probably expected. Let's move on to Liz, who can give us an oversight of the vaccination programme. Liz is the lead for the vaccination programme in Greater Manchester. So Liz, you've got 10 minutes. We're then going to have a 5-minute comfort break. And when we come back, we'll spend the rest of the session on Q&A, because I've seen lots in the chat.
Can I just add that I'm not the lead for vaccines across Greater Manchester before I go into that. So my involvement is as a provider of some vaccines within the Salford area, but also I work very closely with the GM team, so I'm here to just help provide some information for people about where we're up to with the programme. So I can see there's quite a few questions in the chat. I think one of the key questions is, why has there been a delay in getting...
We're struggling a little bit with your audio. Are you using headphones or a mic or something?
I'm not, but I can try again. Is that any better, or is that still...
No, it is a bit...
I just need to speak up a little bit, sorry. So apologies, let me know if that's any better. So one of the questions that we've been asked is about vaccine supply. and what's happening with that. My understanding is that if we take it right back, we didn't have you muted me. We didn't have smallpox or monkeypox vaccine within the UK. We didn't have an active smallpox programme earlier on this year. So as everyone else has alluded to, there's been a real pace with this programme. So one of the key challenges has been to procure enough vaccine. So the vaccine is licensed in America, and there's one licensed in Europe and the UK. So there's been a real effort to try and procure some and to get some of the vaccine over and to scale up production. So my understanding is that there's been a limited supply, and because of the higher concentration in London, that's where the vaccines were initially targeted to. We have now given over 200 in Manchester, and there are plans to be able to vaccinate approximately 3,500 people by the end of August. In September, there will be a further supply coming into the UK, and at that point it will be redistributed and sent in a planned fashion to areas where there are both the ability to give the vaccine and that there's a need for the vaccine in those areas. I don't know if that helps answer some of the questions. There have also been issues about the actual prescribing of it and the legal status. So up to now, as I think Chris Ward mentioned, the vaccines have had to be prescribed. So it's been a case of having a prescriber, somebody to talk to individuals about the vaccine, what's actually involved in administration and potential side effects, and then somebody else has been giving the vaccine. There are plans imminently to be able to change that to more of a nurse-led model, which will speed up the times in clinics and will enable us to actually give the vaccine to more people within defined clinic times. So it's trying to coordinate the rollout with the supply of the vaccine and getting it in time. I think the other question that came through on was, why is it only one vaccine at the moment? And I'm sure Matteo will correct me if I say this wrong, but my understanding is kind of similar to what we did with the COVID vaccine at the beginning, where it's considered to be better to vaccinate more people and give them some protection from one vaccine. We do know that the body has what we call an immunological memory, so your body remembers having that one vaccine. So we can give the second vaccine to complete the course after a month is a minimum time, 2 months, 3 months, 4 months down the line. That will give your body will remember that you've had that first dose. So the idea is to actually try and use as vaccines as wisely as we can to identify the highest, what's considered to be the highest risk people, and give more people a single dose where we can. And then as the supply improves, then we will be making a decision about, at that point, do we vaccinate more people with the first dose, or do we go back and actually complete the course with the second dose for identified people? So if that helps answer. I'm going through the questions here. I think just some practical questions. Is there anybody who can't have the vaccine? I think there are very, very few people who clinically wouldn't be able to have the vaccine. It's usually based on allergies. And in that situation, I would encourage anybody who's offered the vaccine to have that discussion. I've worked within vaccinations for a while now, and that we have strategies to support people, whether it's through needle phobia or anxiety about actually the practical aspects of having a vaccine, or whether it's due to potential allergies to the vaccine. And we can definitely put things in place on an individual case basis to try and facilitate that vaccine. So there are a couple of drug allergies, but I would encourage anybody who is offered the vaccine to come forward and have that conversation, and we can make an individualised plan for people. In terms of side effects, none of us like side effects. Actually, vaccines are very, very well tolerated, and this vaccine, the smallpox, monkeypox vaccine, has been very well received in the people who have had it so far. Like all vaccines, as your body's having an immune response, people feel a bit fluey, a bit unwell, can feel a bit off colour for 24 hours, sometimes headaches, and most people will feel a bit red, a bit red and sore around the vaccination site. It's generally short-lived, and after 24, 48 hours, most people report that their symptoms have resolved. We will be going into the COVID vaccination booster programme in September, so it's important that people are aware about potentially having the vaccines at the same time or separating. And generally we would say for younger men that we would advise to wait 4 weeks in between the monkeypox vaccine and the COVID vaccine. But again, you can have that discussion with the clinicians in the vaccination service.